Well, good evening, everybody. Thank you for your patience. Sorry about those glitches there. And thank you for the introduction, Melissa. So I'm going to go ahead and get right into things here with our endodontics review. Sorry. Again, these are my opinions, and there's no specific product endorsements. I'm going to talk about some specific products, but I'm not endorsing anything. It's just to talk to you about materials and things like that. So I'd just like to thank some of these doctors that were involved with developing this lecture over all these years. There's a saying that if you see a turtle up on a fence post, he didn't get up there on his own. And that's definitely true in my case with some of my endodontic knowledge. So especially for Dr. Eileen Cabanata Logan, my endo mentor in Hawaii, I learned quite a bit from her. So we don't get anywhere without people's help. So here's my outline. And again, I'm just going to get right into things because we're getting late here. So we're going to start out with a little bit about histology. So what are the kind of things that are inside the pulp, and why is that important? So when it comes to some of our diagnoses and figuring out what's going on with a patient's problem endodontically, knowing what kind of cells and tissues are in the tooth can kind of help us key in on that. So we have odontoblasts, fibroblasts, we have some undifferentiated mesenchymal cells, inflammatory cells, connective tissue, vascular tissue, some neural tissues, and then some lymph as well. And then let's talk a little bit about dentin. So dentin comes in a lot of flavors. So initially we have our pre-dentin, which is unmineralized, and then our mantle dentin, which is some of the first dentin that's formed. After that, during root development, we have something called developmental dentin. And then we have our secondary dentin, which is any dentin that's formed physiologically after root development. More specifically, we have tertiary dentin, which is in response to any kind of irritation. And then there's two kinds of that, and I'll kind of differentiate those. So first of all, we have reactionary, which is produced by the original odontoblasts. And then we have reparative, which is produced by those undifferentiated mesenchymal cells after the original odontoblasts were destroyed. So if caries ruins the original odontoblasts, these other cells are redifferentiated into odontoblasts and make reparative dentin. Clinically, they're kind of the same, but on a histological standpoint, they're different. And then also, we have our intertubular dentin and our paratubular dentin. So I'll talk about a little bit about inflammation. So as a carious lesion progresses towards the pulp, you're going to have an inflammatory reaction. Interestingly, for caries, you actually get a chronic response as your first inflammatory response, and you don't get your acute response until you're about a 0.5 millimeter from the pulp. So let's talk a little bit about nerve types. So 3 different types of fibers we like to talk about inside the nerve. So first we have our A beta fibers. They're myelinated pretty quick. They're intermediate in size, and they mediate things like touch, pressure, vibration, and joint positioning. Then we have our A delta fibers. They are very small, again, myelinated, which makes them pretty quick. They mediate cold and some components of cold sensation and pain. Finally, we have our C fibers, which are the smallest diameter. They're non-myelinated, so that's going to make them a little bit slower. These fibers mediate heat and the primary components of hot sensation and pain. And these are often the last fibers to die. And I'll talk about this a little bit more, but that's kind of the reason sometimes you'll have a patient come in with ice in their mouth. They're not having the classic cold pain, they're having more pain to hot things. And that's because the C fibers may be the only viable fibers that are left at that point. A little bit of microbiology of the pulp. As a carious lesion progresses and becomes a periapical lesion, your microflora are going to kind of have a gradient. So more coronally, we're going to have more aerobic type bacteria because we have access to oxygen and nutrients. As we go along the root down to your abscess or periapical lesion, you're going to go to anaerobic facultative anaerobes and then strict obligate anaerobes. So you kind of have, again, this gradient from coronal to apical of bacteria. Another important thing to point out with microbiology is that E. faecalis is often implicated in failed root canals. So often when they go in and culture these failed root canals, E. faecalis is often implicated in them. So something good to know. So let's talk a little bit about diagnosis and treatment planning. So I think, diagnosis is important in anything we do in dentistry, but I think, it really is what drives our treatment when we have an endodontic problem. So Again, we're going to review medical history because we never want to treat a stranger. We're going to get the patient's chief complaint. I find with endo, patients are often telling you in their own words what's going on. Honestly, obviously, we're going to go through a lot of testing and things like that, but patients a lot of times tell you what you need to know to come to your diagnosis. So for endo, we always want to have a pulpal diagnosis and a periapical diagnosis. So for pulpal diagnosis, we have thermal testing, either hot or cold. And then for periapical diagnosis, we have our 3 Ps, our percussion, palpation, and probing, and then our bite stick test. And then we have some adjuncts as well. Cone beam, CT, a great adjunct that more and more of us are using. Your electronic pulp tester, your EPT, and then some tools that you may not need to use all the time, except for extreme cases, your selective anesthesia, and of course your last resort, a test cavity. So these are pulpal and periapical diagnoses. So for pulpal, we can have a normal pulp, we can have reversible pulpitis, we can have symptomatic irreversible pulpitis, asymptomatic irreversible pulpitis, pulpal necrosis, previously initiated therapy, and previously treated. And I'll go through all those later on. For our apical diagnosis, you can have normal apical tissues. We can have symptomatic apical periodontitis, asymptomatic apical periodontitis, acute apical abscess, chronic apical abscess, or condensing osteitis. So let's talk about some of our tests before we get into those diagnoses. So thermal testing. So cold is kind of our standard. And our 112 tetrafluoromethane or endo ice is kind of the standard tool to use. So when we do this, a couple keys to really being accurate with this test. So first of all, nice fluffy cotton pellet. Using a tightly bound cotton tip applicator or Q-tip, you don't get that cold sink and you don't always get that cold right on the tooth like you need to. And then are you dipping or spraying? So a lot of people just spray right on that cotton roll. I find, and some endodontists use like a Dixie cup and actually spray the refrigerant into the cup so you have a liquid in there, and then you dip your cotton, well, not your cotton tip applicator, but your cotton pellet into that liquid and then use that for your cold test. So that is going to ensure that you have a very cold, concentrated cold in the cotton pellet. There's a risk for false positives with this, so you got to be careful where you place it. A jumpy patient's going to jump just by you touching them, and that may give you a false positive. Touching the gingiva may also make them think that they're feeling pain. Also really important when we're doing this is to go to the cervical region of the tooth when testing, because that's your highest concentration of nerve fibers is in that area. Hot testing, so we don't have to do this a lot, but this is a tool that you can use. Because it's hard to test a tooth for hot, you can isolate the tooth with a rubber dam. And the water should be about the temperature of hot coffee. So if you have a Keurig or a microwave, you can microwave some coffee up, or excuse me, some hot water up. You can syringe it onto the tooth with like a monoject. Some people advocate using warm gutta percha. So if you have some kind of warm gutta percha, you could put it on there. And what you're trying to do is stimulate the A delta and the C fibers. You're also trying to replicate what's causing this patient's pain. So oftentimes if they're drinking hot water, that's what's doing that. This can also be used if you're trying to isolate a crack, and what's causing the patient pain is drinking liquid. So it can also be used for a test in a patient who may have a cracked or fractured tooth. So the EPT, for many people, this is really only an adjunct, for me as well. So if I'm not getting good answers from some of the other tests, I may bring an EPT in to see if I even have viable tissue still in the tooth. So oftentimes they're going to give you a number. That number doesn't really matter. It's either a yes or a no. So if they're feeling it and you're getting a number, that means that there's living tissue still in there. There's still viable nerve tissue, and the no means that it's necrotic. You can get a false positive from liquefactive necrosis. So if there's an abscess in there, you can imagine that can conduct and give you a false positive. Metal restorations can also give you a false positive. And one problem with these, and we may not see this as much, but if you have a crown and you can't conduct through that crown, especially like a PFM or a FGC, you can do some bridging, which that means taking like a periodontal probe or an explorer, as you can see in that bottom right photo. Get on that root surface, get below the CEJ, get below the crown, and then use that to bridge the EPT. This doesn't stimulate C fibers either. So if you're farther along in the process of pulpitis and we're getting close to necrosis and there are viable C fibers, they aren't going to be stimulated by this. So then we have our 3 Ps. So when I talk to patients about what I'm testing, I first tell them I'm going to look for the viability of your nerve. I'm testing how healthy your nerve is, and then I'm going to look at the tissue surrounding the tooth. So our first one is palpation. So we're doing digital pressure over the apex, our facial and palatal mucosa, and that sensitivity indicates some kind of periosteal inflammation or perhaps even an abscess. Next, we have our percussion. So we should be using like an instrument handle for this, either on the occlusal or incisal, and sometimes in the buccal or lingual. The sensitivity is going to indicate that there's some kind of PDL inflammation. It doesn't tell us if the tooth is vital or not, okay? So it's also kind of helpful in locating the source of pain, as there are a lot of proprioceptive fibers in the PDL. So this is one thing we can do, because sometimes it's hard for patients to localize endodontic pain. This is a good test in pediatric patients. We can't, and I won't get into that too much in this lecture, but pulp testing on pediatric teeth is not very accurate, but percussion in a pediatric tooth can tell us a little bit more than it can in an adult. Excuse me. Next, we have our probing. So we always want to probe because we want to see what the periodontal condition is. We're also looking for isolated defects in case there's some sort of fracture or a combined endoperio lesion. Always good to check for mobility too. Again, we want to look at our periodontal status, or if there's some sort of trauma, we want to see how our periodontion's doing. Also, is this a tooth that's even restorable? If we've got +3 mobility, maybe it's not worth doing a root canal. So it's good to ascertain this too. So always good to take 2 instrument handles or 2 firm instruments. Our fingers are squishy, and we're going to alternate force back and forth in a facial lingual direction. We also want to see if a tooth is depressible, because that's not a good sign for the prognosis of this tooth if it's depressible. And it's basically going to tell us the integrity of the attachment apparatus, okay? And again, like I said, if there was trauma, periodontal disease, maybe they had ortho where they move things too fast. So just good to ascertain all those things before we get into treatment. So let's talk about pulpal diagnosis. So first we have a reversible pulpitis, and that means that our pulp is capable of healing. So we can have an asymptomatic irreversible pulpitis. So the patient is asymptomatic. They may or may not be having pain, and this is usually going to be from a carious pulp exposure or mature tooth. Internal resorption or a hyperplastic pulpitis, like a pulp polyp, can also cause this pulpal diagnosis. Our next pulpal diagnosis is kind of our classic toothache. That's our symptomatic irreversible pulpitis. So we're going to have spontaneous pain, the pain that wakes the patient up. It can be throbbing. Changes in position can make it worse. If the patient puts their head down below their heart, maybe that hurts more. The pain lasts when they drink something hot or cold. Often the nature of the pain is like a deep, dull ache. The classic, it's radiating to the patient's ear. And we should be able to reproduce this patient's chief complaint. Referral to other sites can often happen here, and that's where we may want to use that selective anesthesia. And as our pulp becomes more necrotic, that pain oftentimes decreases. So pulp necrosis means that we don't have any more viable tissue. So that means it's non-responsive to any kind of vitality test, cold, EPT, hot, and there's no pulpal pain. So the nerve is completely dead at that point. Next, we have previously initiated therapy. That's any kind of unfinished root canal treatment, whether it's a pulpotomy, pulpectomy. So somebody accessed that tooth, began the root canal, didn't complete it. And maybe we would notice that there's some kind of medicament in there like calcium hydroxide, or maybe nothing. But this is an incomplete root canal. We have previously treated, which means that there's some sort of root canal there. Maybe some instance where you might see some Sargenti paste or some other kind of non-standard endodontic treatment done. But our assumption is that the provider who did the endodontic therapy meant for this to be definitive treatment. So let's get into our apical diagnosis. So first of all, we just have our normal apex. So it's non-sensitive to percussion, non-sensitive to palpation. We look radiographically, our lamina dura is intact all the way around, and we have a uniform PDL space. Next, we have our asymptomatic apical periodontitis. So when it comes to pain, we don't have any pain. Swelling, there should be no swelling, no sinus tract. When we palpate, it should be within normal limits. biting is within normal limits, and percussion is within normal limits. But when we look at a radiograph, apically, you may see some sort of radiolucency. Next, we have our symptomatic apical periodontitis. So obviously there's going to be pain because it's symptomatic. There shouldn't be any swelling or sinus tract. There may be some tenderness to palpation. Biting also may be painful. Percussion is normally going to be painful. And then radiographically, we may or may not have an apical radiolucency. Next, we have our acute apical abscess. So pain is definitely going to be present and swelling is present as well. Sinus tract, probably not, but there could be one. Palpation is going to be painful. We really want to key into that. Biting is going to be painful. Percussion is going to be painful. And the radiograph is either going to be within normal limits or you're going to see some sort of apical pathology. Next, we have our chronic apical abscess. Oftentimes with these, there's no pain or it's episodic pain. And there's normally not swelling because these are often, you have your gum bump. So you have that sinus tract that's draining and relieving that pressure so the patient may not have pain there. Or they may say, oh, I get this little pimple or gum bump and I just pop it and it drains and I feel better. So yeah, normally you'll see that sinus tract. Palpation may be tender. Biting should be within normal limits. Percussion may be tender. And then radiographically, some sort of apical pathology is normally present. So next we have our condensing osteitis. So this is normally from some kind of chronic inflammation, not always a pulpitis. So, or maybe even like a reversible pulpitis that's been long-standing. So it's a localized overproduction of apical bone. Oftentimes we're seeing the apices of mandibular posterior teeth. And like I said, there was some kind of chronic pulpitis or a pulp necrosis. And that low-grade inflammation caused some increased bone deposition in that area. So our diagnosis is basically going to come down to, do we need a root canal or do we not need a root canal? And honestly, sometimes it's okay to watch and wait. And sometimes patients are really bad historians or they're not able to localize the pain and you can't reproduce the symptoms. So you can't reproduce symptoms and come to a definitive diagnosis. We don't always want to jump into these things, and it's okay to wait a day or two for the pain to present itself the way it needs to so we can come up with a proper diagnosis. Because at the end of the day, the diagnosis is going to drive all of our treatment. So let's talk about radiographs, first of all. So you always want to make your own pre-op radiograph, both for medical legal reasons and just so you know what's going on. Also consider your angulation when you're taking them. Sometimes you might have an assistant who takes a really steep PA and it can elongate the roots and things like that. So just be aware of all that. So a study by Breinhoff said that when you take multiple radiographs, you increase your diagnostic accuracy by about 90%. So, and we also have cone beam now, and I'll talk about that later. So in addition to all these PAs in a bite wing, many of us have the opportunity to get a cone beam and look at the morphology a little bit better and know what we're getting into. So at the end of the day, this should be one of the last things you look at, though. You should be doing all your diagnoses and then looking at your radiograph to pull the whole picture together. And as my mentor said, like a good audio mnemonic to think about is crown down and all around. Because sometimes that problem may not be what we think it is. So we want to look at the restoration and the quality of the restoration, the bite, the periodontium, all that sort of stuff. We don't want to focus in just on that periapical radiolucency or that widened PDL, because there may be other things going on in that x-ray that we might miss. So I'll take you back to dental school again here real quick here. We're going to talk about our buccal object rule, or our slob rule. So slob is, same lingual, opposite buccal. So when we talk about the x-ray head, the lingual object is going to move in the same direction as the tube head. And your buccal object is going to move in the opposite direction of the tube head. So when you look at this radiograph on the bottom left, the tube head is straight on with the tooth and shooting the ray straight on. If I move that tube head distally, and our buccal object is going to move mesially. And so that's how we can kind of test. So again, that buccal object is moving in the opposite direction of the tube head. And that can be used in a horizontal vertical direction. So if our tube head goes more inferior, then our buccal object should move more superior or more coronal. Other things to look for in radiographs as we're looking for them, additional canals. So some signs for additional canals are one thing called a fast break. where you can see that canal is really clear and then all of a sudden it kind of disappears. That may represent a canal division. Root outline is unclear, so if it gets a little bit weird looking, maybe there's multiple roots there. And then obviously a canal not centered in a root. So canal should go straight down the root. So if it's off center, it probably has a neighbor or a friend in that root living with it. So periapical radiolucencies. So good mnemonic for this is GAC. So, a lot of us just say, oh, that's just an abscess, but unless you do a biopsy, a lot of these aren't actually always abscesses. So in order of how often they occur, you're normally going to have, most of the time, either a granuloma, then followed by an abscess or a true cyst. Okay, so I know many of us probably just say in layman's terms that's an abscess, but we don't really know what that is. So oftentimes when we do an apicoectomy, we'll do a biopsy to make sure that it is not a true cyst. So a little bit on CBCT here. So the Academy of Endodontics and the Academy of Maxillary Radiologists put out this joint statement in 2015. And if you get a chance to read it, this is really good. And it gives you recommendations on when to use a limited field of view cone beam. So they gave 12 recommendations, and 9 of them suggest that using limited cone beam should be considered the imaging modality of choice. So for initial treatment, what we're often going to be doing preoperatively, a tooth like a first maxillary molar, helping us determine where that MB2 is or if it's even present. Intraoperatively, if we come across calcified canals, using cone beam can help us kind of find our way again. And then postoperatively, we can look at, if we clean and shape properly, if we have a good fill. So cone beam has really kind of changed things quite a bit in endodontic diagnosis, and I think we're going to end up using it more and more in the future. So sometimes our pain is not from an odontogenic source. And these are some pretty common sources of non-odontogenic pain. So myofascial, so muscular pain, from clenching, grinding, something like that. Cardiac pain, obviously, an MI can refer to the jaw oftentimes. There's neurovascular or headache pain, neuropathic pain, some kind of pathology in the nerves, psychogenic pain, and then pathology, like your sinusitis. So a good mnemonic for this is my cat never needs puppy power, to remember those. So let's talk about access and then morphology and anatomy. So access. So what is the goal of access? So we want to get straight line access from the orifice in the coronal aspect all the way to the apex. And there's some reasons for this. So number one, if we have good straight line access, we can see all the way down, we have good vision, and we can find all of our orifices. And it allows us to see our dentin roadmap, which I'll talk about later, and find all of our canals. Next, it's going to reduce any curvature in our instruments and in obturation. So we don't want to be putting additional bends in these instruments, because that torsional strain can cause separated instruments. So we want that instrument to go into that root canal system as straight as possible before it starts engaging dentin. Also, just placing gutta percha around a corner can be kind of difficult. So that straight line access can help us with that. Instrument control is a little bit easier, so it's just easier to drop files in, to feel what you're doing. Again, fewer misadventures, like I said, putting torsional strain on files. Conserving tooth structure because we're not hunting around looking for things. And then this is really important too, it's a reservoir for irrigant. So, we want fresh irrigant to get in there to kill bacteria. And I'll talk about that more later too, but our instruments aren't getting everything. So we want to make sure we're getting good irrigation in there. So this study by Deutsche Musikant is really nice. And I wish I would have known this sooner in life. I think it would have kept me out of some trouble. So they found that you usually have 6 millimeters from the chamber floor, 6 millimeters from the occlusal floor to the chamber ceiling, another 8 millimeters to the floor of the chamber, and 11 millimeters to the furcation. So if you take whatever burr you use to access, whether it be a 557 or some sort of round burr, and you measure it at 6 millimeters, when you drop in, you should be pretty darn near the top of the pulp chamber. And if you're getting to 8 millimeters, then you're getting kind of near the danger zone. So this is a good way to kind of help yourself stay out of trouble. It's also kind of important to go back to that real quick. Again, when you have something like a crown or something like that, that can also help you because you can lose some of your anatomic landmarks. So this study by Krasner and Rankow came out in 2004, and it talks about the roadmap of the pulp chamber. And these are just some basic rules after you've accessed a tooth to look and help you find orifices. So number one is the law of centrality. And so your pulpal floor should always be located in the center of the tooth at the level of the CEJ. Next is our law of the CEJ. And the CEJ is the most consistent, repeatable landmark for locating the position of the pulp chamber. Third, we have our law of concentricity. So the walls of the pulp chamber are always concentric or within the external surface of the tooth at the level of the CEJ. So if you think about, if you've probed around that tooth, you kind of know where the level of the CEJ is, and then you can kind of have an idea of what the shape of that orifice is going to be, if that makes sense. Next, we have our law of symmetry. So this is good for everything except like maxillary molars. But our orifices are going to be equidistant from a line drawn in a mesial distal direction through the pulpal floor. So if you look at that bottom left photo, you can see how those mesial canals and distal canals are equidistant from that line down the middle. Now we have our other law of symmetry. And again, except for maxillary molars, the orifices are going to lie in a line perpendicular to a line drawn in a mesial distal direction across the center of the pulpal floor. And again, on that bottom right, you can kind of see that, how that looks. So then there's our law of color change. So the pulpal floor is always going to be darker than the wall. So if things start getting darker, that's kind of clue you in that you're at the floor of the chamber. Your orifices are always going to be located at the junction of a wall and a floor. And so that's that FWJ that you see there. That's a floor wall junction. The orifices are always going to be located at the junction of walls and floors. They're always going to be located at the angles of a floor wall junction as well. And they're usually going to be located at the terminus of a root development fusion line. And so that's really evident if you're using like a dental operating microscope or really strong powered loops. You can actually see these fusion lines where, as a tooth germ formed, two of them came together and makes like a fusion line. There's literally a line on the floor there where that happens. So for this, I just want the big takeaways for this. Some of the green are some of the differences. So these are really important to know, both in clinical practice and for testing purposes, to know how many canals are in different teeth. So the exact percentages I don't think are super important because those can change based on the study that you're looking at. But just having a general idea when, like for instance, a first premolar in the maxillary, 69% of the time it's probably going to have 2 canals. So when you access that tooth, you should always be thinking 2 canals until proven otherwise. Likewise, with a second premolar, most of the time it should be 1 canal, and maybe only a quarter of the time there should be 2. So when I get into a second premolar in the maxillary, I'm thinking 1 canal. The big one to take away home on this one, and many of us should know, that first maxillary molar, again, depending on the study, MB2 should be present over 80% of the time. And I think most people would argue it's almost always there. It may not always be instrumentable all the way to the apex. You may just, may end early, but you should be able to open it up and instrument it a little bit. So you should always be looking for that MB2. On our mandible, some of the takeaways, so our centrals and laterals, good chance that our central and laterals are going to have 2 canals. It's about 60-40, so which is enough for me to be thinking, okay, 2 canals on a central or lateral mandibular. On our first premolar, again, 75% of the time-ish, it should have 1 canal. And our second premolar should almost always be 1 canal. When we're looking at our first molar, oftentimes, about 30% of the time, we can have a 4th canal, this so-called middle mesial canal. So in between your mesial buccal and mesial lingual, there'll actually be a 3rd canal oftentimes, and that's your mesial middle mesial canal. And again, that one may not be one that can be instrumented completely to the apex, but you should be looking for it. Another one to be kind of aware of is these C-shaped canals. Now, there's the indices for what all these different types. There's like, a semilunar, a semicolon type. You don't need to know all that. I think the big take home from this slide is that these exist. Radiographically, you'll often see like a conical shaped second molar. When you access these, it's not going to look like your normal second molar. It's going to look pretty weird. Pretty low incidence for the most part, except in the Asian population where it's about 30%. So, and these are very difficult, and that's why you want to be aware when you're getting into them, because you cannot instrument these completely, and you're really depending a lot on chemical disinfection to remove tissue and bacteria. And so this may be one that you don't want to get into. This may be one that you want to send to your friendly endodontist. So let's talk about whine classification. So whine classification is basically talking about coronal to apex, how many entrances do I have and how many exits. So for your type 1, I have one canal going all the way down from the crown of the tooth to the root. For our type 2, I have 2 canals that go into one foramen with one exit. My type 3, I've got 2 orifices that go all the way down the root and exit as two exits. And then our type 4, that's one entrance, one orifice, and with 2 exits out the apices. So a good way to remember this one, if you look at the way they look at I, Y, 2, and peace, that last one kind of looks like a peace sign. That can kind of help you remember which one's which here. So let's talk a little bit about working length determination. So working length can be very variable. So just using a radiograph to determine working length is not super accurate, especially as we get older. More cementum is deposited. That apex is not always right directly at the bottom of the root, as you can see in this photo here. So that root, that file is way out the apex, but on a radiograph, that may look like you still have your 1.5 millimeters. So different views are also recommended, different shots. So our apex locator is really our gold standard, and really this is what we should be using all the time, and then just confirming with a radiograph afterwards. So it uses a ratio method. That's not super important to know. They don't have to be calibrated. This study in '96 showed that they were pretty darn accurate within 0.5 millimeter. So again, using them in conjunction with a working length film can get you a very accurate working length. Excuse me. So let's talk a little bit about cleaning and shaping. So we are trying to remove all the contents of that pulp space because there's a lot of crap in there, tissue, debris, bacteria, byproducts. We want to get all of that out of there and cleaned. So we want to get nice straight line access and be able to clean coronally to apically while maintaining a central access in the canal. We don't want to be moving our canal all over the place. We want to keep our apical constriction small and it's in an original position. And that's important when we go to obturate, because if we open that up too much, we can push materials, either our irrigants or our gutta percha, out into the periapical region. And we want to continuously tapering, very smooth funnel shape preparation. That's going to both be good for our obturation and then also for our cleaning and shaping in terms of our irrigation. You need like an ISO 35 really at the minimum to get irrigant in all the way and clean properly. So very important when we're doing cleaning and shaping to keep these things in mind. So I'm not going to talk a lot about specific instrumentation because there's so many systems out there. I just want to talk about some of the basics. So, we have our conventional hand files, which can either be stainless steel or nickel titanium. Our rotary nickel titanium, which I think most people are using. Also our sonics and ultrasonics. These are really, really great for removing dentin ledges, that tertiary dentin if you're looking for a canal like MB2, applying energy to a post or a file to get it to come out. These can cut safe-sided. They can be used to smooth your orifice and make things a little bit cleaner. So this is a really great tool. So some types of files, excuse me. We have our C file. That C stands for calcified. These are very small, rigid files that can be used to get into calcified canals to start getting a glide path. Our K files, which are using kind of a reaming motion, those are used to get glide path, establish initial working length, and to keep patency. We have our headstrom file, which kind of looks like a spiral staircase in cross section. That's used with kind of a pulling motion. Those are often used in retreats. I don't use those a lot, but if you're trying to grab like a perch or something like that, they're great for that. And then our rotary files, which again come in several systems. So American Academy of Endodontics has these golden rules for a rotary technique, and I'm going to kind of go over those. So, first you want to assess your difficulty. So, these are very flexible files, but you need to know if you have like a 90-degree turn at the apex, you don't want to be forcing these files down that. Again, like I talked about earlier, straight line access is super critical because we want to limit the amount of bends in the file. Really, we want to hand instrument to an ISO 20 to get patency to have that glide path. So that glide path is important to make sure that you're not moving your apical foramen, you're not transporting or ledging. Really important to use a light touch and a very low RPM. a crown down technique, which I won't get totally into that, but crown down, basically, you're removing the most contaminated material from the coronal aspect first, and then taking chunks as you move more apically. So the idea is to not extrude any material down out the root apex. Helps reduce flare-ups, helps to, get us better healing. And then replacing instruments frequently, especially if you're working some of these files really, really hard, that torsional strain can build up over time. Sterilizing them can also damage them. So you want to be checking your instruments and replacing them frequently. So some of the benefits of rotary instrumentation, it's going to be faster, less fatigue. It is going to cost a little bit more. There's a bit of a learning curve. Like I was talking about the crown down, it's designed to pull the debris out and not push it out. They're very flexible, so less transportation, and they're going to be a little bit more fracture resistant, but these can break. Even a brand new file could have a defect and break, so you want to be very careful with these. So I'm going to talk a little bit about chemical disinfection. So Ove Peters did a study that showed that only about 50% of your instrument actually touches this tooth surface. So when you look at these two photos, on the left, we have that smear layer, all those little dental tubules, your file is not getting into that. And then on the right, we have fins and isthmuses and all these irregularities. So our file is never going to touch all those dentin walls. So we need something to get into all those spaces. So let's talk about our irrigation. So first of all, we have our 8% full strength sodium hypochlorite, and that's our gold standard. And what that's doing is removing our organic portion of the smear layer. It's really good at dissolving necrotic tissue. It's germicidal. It's going to detoxify endotoxins, and those are often implicated in periapical radiolucencies. It's going to be your lubricant. As you're working those files in, it's going to work as a lubricant. And it is also a bleaching agent and deodorizer. It's really important to remember that diluting it reduces all your beneficial effects. So I know people get a little skittish about using this, but if you're using safe-sided needles, and if you're measuring your needle to know where your working length is, and you're keeping that needle short of your working length, and you're not jamming the needle down into the root canal system and forcing things hard, it's very unlikely that you can cause damage to the patient and hurt the patient with this material. That being said, we also have our 2% chlorhexidine gluconate, and it's really important to remember that 2% is the percentage we want to use if we're doing this. So on the bottom right, you see that Endo-CHX. That is a chlorhexidine that is made specifically for root canals. That also comes with a surfactant in it to help with lubricating. So while this is a good material, we know chlorhexidine is great at killing stuff. It's not going to dissolve your tissue. So any kind of necrotic tissue, it's not going to dissolve that. Now, you may want to use this in an open apex case, so an immature tooth, or perhaps a tooth that's really been eaten up, the root's been eaten up by an infection, and we know that that's wide open. Maybe that is a situation where you'd want to use chlorhexidine. There's also some studies that show that it may be more efficacious against E. faecalis, so if you're doing a retreat, this might be a good material to use in a retreat. Really important to not mix this directly with sodium hypochlorite or mix them in the tooth together. It can actually form a carcinogenic precipitate. So you're making a carcinogen and then also blocking yourself out. So some dentists do like to irrigate a final irrigation with chlorhexidine. If you really want to do that, I'd recommend rinsing with saline or something like that to get that sodium hypochlorite out before using the chlorhexidine. Next, we have EDTA. So it comes in a 17% formulation, and this is a chelating agent, which, if you remember your Gen Chem, that means it pulls calcium out of solution. So our inorganic portion of the smear layer, this is going to help open this up. So what I like to do with this, if you have sonic activation, I'm going to irrigate with this for a minute. I'm going to activate it with a sonic activation, so that's going to help stir things up and bring all that calcium and all that smear layer into solution and kind of precipitate out. And then I'll do one more rinse with my sodium hypochlorite to get all that precipitate out. And now that all those dentin tubules are wide open, I can get my sodium hypochlorite in there to kill more bacteria. Citric acid is also used for that, but I'd say most people probably are using EDTA. So intra-appointment medicaments. Sometimes if we just do a pulpectomy or we have a hot tooth or a tooth that's bleeding, we may want to use calcium hydroxide. Ultracal is a brand, Multical is another one. It has a very high pH, and that's going to alter the environment. And I'm going to use that term again later on down the road, but it's just going to make it difficult for bacteria to live there. So it's antimicrobial. It's going to dissolve tissue. It favors calcifications. This alkaline phosphatase is going to help bone regeneration of periapical radiolucency. It's going to help grow new bone. If you've got tissue, so it's got limited tissue necrosis, so if a little bit gets out, that's not a problem. If you have a weeping canal, so it's just bleeding, you don't want to obturate, this is really great. One technique for that is you can actually use powdered calcium hydroxide. And if you have a really angry tooth that you just cannot get the heme to stop and you got to close things up, you can actually take some powdered calcium hydroxide and drop that down in the canals to help stop the bleeding. Again, when I was talking about changing the environment, if you have some kind of resorptive lesion, either internal resorption or external resorption, doing a pulpectomy and then placing calcium hydroxide can help slow that process down. And it's effective for about a week. So let's talk about obturation. So with obturation, we're trying to replicate the root canal system and maintain materials inside. So kind of thinking about mummifying all the bacteria that we weren't able to kill. So we want to get a tight seal to fluids, bacteria and byproducts. So we're sealing in any bacteria that we didn't kill, and we're sealing out any nutrients that could allow them to flourish. So gutta percha, again, is kind of our standard for obturation. We're often using it in the beta form. It's recommended that you disinfect it prior to use so you can submerge it in your sodium hypochlorite for about a minute. And then there's lots of ways to place this: cold lateral, warm vertical, carrier based. So I won't get into all those, but just basically remembering that gutta percha is a good inert obturation material. So ironically, gutta percha is not actually mostly gutta percha. It's actually mostly zinc oxide, with about 20% of it actually being gutta percha. And then there's some waxes and resins, metal sulfates to make it radiopaque and kind of be a binder and hold things together. So it's normally standardized into points. We did an O2 taper from a 15 through 140 for your ISO. There's some non-standard ones like fine, medium fine. And then some rotary systems have specific gutta percha that correspond to a file. So maybe like an 04 and 06 taper. So if you're using a system like that, you may need to use the gutta percha that comes with it. So a little bit about sealers. So a good sealer is going to provide a seal when it's set and adhere to our canal walls. We want it to be very radiopaque so that we can see it. Shouldn't stain, so it doesn't percolate up like on an interior tooth. Should be insoluble to fluids. Again, we don't want nutrients to get in. Easily mixed, a long working time. Non-irritating, very important, because sometimes sealer gets pushed out the apex. Should be easily removed if we have to do a retreat, and it should be somewhat bactericidal. So some of our classic ones are ZOE cements, like your Ross root sealer. Some of us may have used that. I know I have. I've been told they don't even make this anymore. There's some calcium hydroxide based, like Silapex, glass ionomer based, like Heatech Endo or Active GP, and then our resin based, like AH Plus or Epiphany. This new kid on the block that many of you may have heard of and may be using are the bioceramic sealers. So EndoSequence is actually the one I'm aware of. I'm sure some knockoff brands or generic brands are coming out, but it has a lot of advantages. It's very biocompatible. It's hydrophilic. It bonds to the dentin. Very antibacterial during its setting phase. There's this talk of this single cone technique. So you actually fill the canal up with the material, place your master cone and sear it off and you're done. Some endodontists are doing that. One of the disadvantages of this is it may be very difficult to remove. So if you are using this material, it may not be suitable for a retreat. So maybe this is something you want to use on a retreat. You know, it's this tooth's last chance. And then just some of the materials that are involved in its composition. So let's talk a little bit about complications. So first, let's talk about endodontic misadventures. So we have instrument woes and obturation woes. Some of our instrumentation woes, transportation, so that moving the canal is no longer centered, ledging, perforations, those can be like strip perfs or straight through and through perfs if we're not careful, separated instruments. And then for obturation, we can have an overextension and an overfill. Again, you know, if you don't check your stop and you open your apex up too much. Voidosis, if we're not careful when we're obturating, we get voids. If we are not careful with obturating, we can get vertical root fracture. And then sodium hypochlorite extrusion is another issue. So ledging and transportation, this picture kind of talks about what ledging and transportation is. So I think this is a good like diagram just to kind of understand what's happening there. So what are some of the things that can cause ledging and transportation? So if your file is too stiff, too large, if you don't recognize that there's curvatures, some really important ones. So failure to establish your working length correctly, and you're going to be short, or failure to maintain that correct working length. Failure to recapitulate. So what does that mean? You know, really between each rotary file, you should be taking a clean K file, maybe like a 15 or a 10, and going down and make sure you have your glide path, remove any blockages that you may have formed, and then go with your next file. Overfiling, and then just not having a glide path at all. So perforations, these are no bueno. There are some that can have a good prognosis. So if it's fresh, you catch it right away when you've done it and you repair it. If it's small, and if it's more apical, so way down towards the apices, or more coronal. Some poor prognosis, if it's an old perforation and we didn't find it, very large perforations, or if it occurs in the sulcus or crustal, those are not so good. So what are some of our options to repair? So our top two, so MTA kind of classic repair material, our bioceramics, which are pretty similar to that endo sequence that I talked to. Those are nice. Those have a little bit better handling properties. They're going to settle a little bit faster and handle a little bit better. But they're going to be a little bit more expensive because it's a newer product. Vitrobond is always an option if we don't have anything else, or glass ionomer, especially and specifically Gerastore endodontists like this. There's some studies that show that you actually get fibroblast attachment to the Gerastore, so that's kind of the gold standard if you're going to use a glass ionomer for a repair of a perforation. So overfills and inadequate fills. So, you know, when you see this picture here, what probably happened is they didn't have a good apical stop. You know, they didn't know. When I say apical stop, that means, you know, you take your master apical file, and if you tap on it at your working length, it shouldn't go any farther. It should stop there. So that way, when your gutta percha that matches that ISO, when you place that, that shouldn't go beyond the working length. Obviously, this one did. And so it's bad for a couple reasons. You know, gutta percha is pretty inert, and a lot of sealers will go away, but you're giving a source for bacteria to hide, a chronic source of inflammation. So if you have a periapical radiolucency, you're kind of stacking the deck against it in terms of healing, if you have any kind of extrusion or overextension. Inadequate fills, so a couple problems with those. One, it may be a sign that the canal isn't sealed properly. So someone may see what you did later on and think, I don't know if they instrumented that. You know, we look at number 31, I don't know if you went down there with a file and cleaned and shaped that properly because you're short. So I may think that I might see this in a year and say, oh, it's not healed because it was short. It's a place for bacteria to hide out and flourish. Again, when I see voids, I'm thinking that maybe it wasn't done well. So, I mean, there are some pretty bad looking root canals that can be successful, but you don't know who's going to see your work after you've done it. So it's better to do a good job. So a patient's not getting a retreat in a situation where they might not need it. So sodium hypochlorite accidents, let's talk about those. So this is kind of like one of our worst nightmares. So there's going to be immediate extreme pain when this happens. And there may be swelling or bruising that occurs. Again, this material is meant to dissolve tissue, so you may have some necrosis. Often you're going to see that in the wide open apex case. So you really want to be careful in these. Like I was saying earlier, if you know your working length, you can take your irrigation needle and measure it 2 millimeters short. You should, that way you can get your irrigation down along the root surface, down along the root, but not get too close to the apex. Again, we want to use safe-sided needles, and we don't want to force our irrigants. If we're having to push hard, we're doing things wrong. So what's the management? So first calm yourself, and then you want to calm the patient. You want to immediately augment your anesthesia. So you want to give them some more numbing, maybe some Marcaine, but you want to supplement whatever anesthesia you gave them. So initially for the first 6 hours, you're going to give them a cold compress, and then you're going to alternate to a warm compress after that for the next 2 days. Definitely want to hit them with analgesics, especially some kind of NSAID. And if you want to use an opioid along with that, that's fine. And definitely an antibiotic, because there may be a hematoma, and there's probably some necrotic tissue. We don't want that to get infected. If we have airway involvement, we want to refer those immediately. And then really good to bring these patients back on a daily recall. Because first of all, as we know, bruising is going to progress and look worse and worse. So we want to keep an eye on this patient, make sure things aren't going south, and then just to also kind of comfort them and know that you care or that something happened, so we can keep them close, because things are definitely going to look worse to them and to you before things get better. So let's talk a little bit about traumatic injuries. So first, we're going to do an evaluation. So we're going to look at all of our soft tissues. My friend in the picture beforehand, he'd actually gotten hit in the face with a bungee cord. So most of what you saw there was just a laceration to the lip. So you may want to consider some radiographs to look for embedded materials. If teeth have broken, there may be fragments of tooth in there. We want to look at our lips, our tongue, our mucosa. We're looking for sulcular bleeding that may key us into some alveolar bone fracture. We were looking at our alveolar process. Are the teeth moving as a unit? That's not so good. That means we have some kind of alveolar fracture. Or are the teeth moving individually with their mobility? Again, we want to take multiple radiographs at multiple angles because we're looking for fractures. This may be a time to look at a cone beam. And then we want to get baseline vitality readings in all the teeth that have trauma. So the WHO has a classification system for fractures. I'm going to go through that really quick. Some of you may know the Ellis system, but this WHO is a little bit more simplified. So first we have our enamel infraction, and that's any kind of like incomplete fracture or crack in the enamel, but we haven't lost any tooth structure. And then the next fractures are either going to be uncomplicated or complicated, and that's basically talking about, do we have pulp exposure or no pulp exposure? So an uncomplicated crown fracture, we have a little bit of loss of enamel and dentin, but no pulp is exposed, just that little snaggle tooth. Or we can have uncomplicated crown root fracture. So enamel's fractured, maybe coronal and radicular dentin, and maybe some of the cementum, but again, no pulp exposure. Then we have our complicated crown fracture. So we have an exposed pulp, and our complicated root fracture. Again, our radicular dentin and cementum are involved, and the pulp. And then we may further classify that according to how the coronal fragment is displaced. So here's that WHO fracture classification diagrammatically. This dentaltraumaguide.org is really, really good, kind of has very up-to-date info on how to treat a lot of the trauma. I'm not, that's a lecture in itself, and I'm not going to get into all that. If you want to know more about that, it's kind of out of the purview of this lecture, but there's a lot of good information at that site. So going back here real quick. So first of all, we just have our concussion. That's the first one. So not any like visible signs from that. The tooth just got bumped or bruised, might have some transient cold pain, and that's it. And then we're going to kind of move into some more traumatic fractures. So first we have our subluxation. There's not going to be any displacement. You're just going to relieve the occlusion a little bit for the patient's comfort. You can put a physiological splint on them, but that's not necessary. And then you're just doing recall and observation for them. Next, we have our intrusive luxation. So that means the tooth's been pushed apically. So if that tooth is immature and has an open apex, you want to just monitor it, because a lot of times that root formation is what's driving eruption. Increased root formation may allow that tooth to re-erupt, and we may not have to do anything there. However, if it's a mature tooth and the apex is closed, we may want to luxate it a little bit with forceps to get it back into place. That's the surgical repositioning if we need to. We're going to put them in a physiologic splint for a week to 2 weeks. And then at about 1 to 3 weeks, we want to start thinking about doing a calcium hydroxide pulpectomy and then obturating. Now, why is that? When you've intrusively luxated, we've crushed the blood supply to the tooth. And so, as one of my endo mentors said, it's lost its ability to protect itself because no inflammatory cells can get in there and protect it from bacteria. So it is going to become necrotic at some point. And we know that if we do vital root canal therapy, we're going to have better outcomes if it's necrotic. So, we're going to splint this, get it back into place, and then just go in there and go ahead and do the pulpectomy at some point before the patient becomes symptomatic. Next is our lateral luxation. We're going to reposition our tooth. Again, a physiologic splint from anywhere from 7 to 21 days. We're going to relieve the occlusion so we're not banging on that tooth. If it's a mature apex, we're going to observe it. If we get signs of necrosis or resorption, we want to do a pulpectomy for about a month, and then we're going to obturate it. If there's significant displacement greater than 5 millimeters, we want to consider doing the root canal right away. Again, in our immature apex, we can just observe and see what happens. Next is our extrusive luxation. We're going to reposition the tooth, physiologic splint for 7 to 21 days, relieve the occlusion as necessary. Mature apex, we're going to do a root canal or observe, and then an immature apex, we're going to observe. So for our root fractures, this is why we want to get those multiple angles. The ray of the x-ray can sometimes, we want to get it to pass right through that fracture where we may not be able to see it. So that's why we want to take multiple angles. So for a horizontal fracture, some of the factors that are going to affect prognosis, the height of the fracture. So the more apical the fracture, the better we're going to be. How mobile is the crown, and then any pre-existing conditions, periodontal status, if it had a lot of caries, things like that. If we have a vertical fracture, then it's hopeless and that tooth needs to be extracted. So for root fracture, the treatment, if it's mobile, we're going to splint for 3 to 4 weeks, and we want to monitor vitality. And then there's a couple pathways that we're going to go down. So if we're monitoring it, no periapical radiolucency occurs, then we'll just obturate the coronal segment. That apical segment can remain viable. If we find that there's a periapical radiolucency at the fracture site, we're going to do calcium hydroxide pulpectomy until that resolves, and then you're going to just obturate the coronal segment. If there's a periapical radiolucency at the apex, we're going to go ahead and do apical surgery, remove that segment, and obturate the coronal segment or extract. And that's really going to depend on the location. So if it's not halfway down or more, removing that apical part of the root, we may not have enough crown to root ratio to have a good prognosis for that too. So that's a call you're going to have to make depending on where the fracture is located. So this is from the AAE's Colleagues of Excellence. They send these out to people. I think the ADA members, they're really good. If you go to the AAE site, you can also pull these up. I'm not going to go through all these, but this is just kind of good for you to have because what always is going to happen here, it's going to be Friday night or a weekend or some very inconvenient time when a patient's going to have the trauma, and you're not always going to be in the right mind to remember, okay, how long am I going to splint this? What's my treatment? So it's kind of good to just have this printed out in a convenient location to look at it and kind of prepare yourself for what you're going to decide to do. So again, I won't go through all these, but this kind of tells you your splinting time and your radiographic follow-up. So let's talk a little bit about avulsions. So a tooth's been completely lost. So the first thing we want to do is replant it immediately if we know where it's at, or as soon as possible. The next thing we want to do, if we have to transport it to you, these are kind of the best transportation solutions. So, we talk about Hank's balanced salt solution. I know all of us have that like sitting in our back pocket. I don't know anyone who owns this, but you can get it on Amazon in case you want to carry it around and be the hero at the soccer game if someone loses their tooth. Some of the other things that you can use are milk, saline, or even the patient's own saliva. So if they're going to transport it to you, the patient can put it in their mouth or maybe even wrap it in some saran wrap. The real important thing here that I'll talk about is that we want to make sure that those PDL cells stay viable. So we don't want to scrub that tooth or remove any of that. We want to make sure we keep viable PDL cells. So the patient's in your chair now, you want to make sure you numb them up really good because this is going to be uncomfortable putting the tooth back in. So we want to flush the socket out and get all the coagulum out. So there's going to be coagulated blood in there that's going to prevent you from getting the tooth all the way back in. So clean that out really good. Depending on how long the tooth has been dry for, we may want to soak it in some kind of sodium fluoride to strengthen it and to make it a little more resistant to resorption. Next, you're either going to take your fingers or forceps and place it back into the socket. You'll take a radiograph to verify that it's in the right place, and then you're going to put them in a physiologic splint for 2 weeks. You may want to think about antibiotics. So if they're over 12 and they have all their teeth erupted, you can think about doxycycline. That's going to get in the gingival curvicular fluid a little bit better. Make sure their tetanus is up to date. You're going to put them on a soft diet and then chlorhexidine, like Paradex, twice a day for 10 days. And then within about a week, we're going to want to initiate root canal therapy before we remove the splint. Some people recommend maybe leaving that calcium hydroxide in place for a couple weeks. That's, again, I talked about changing the environment. That's to help prevent resorption. And then you really want to follow up on these every month and every couple months and then yearly because these teeth are going to be at risk for resorption or ankylosis. So my friend here, after we got him cleaned up and numbed up, just took some forceps and we put that tooth back into place. So he only did like a lateral luxation in this situation, but we ended up doing a root canal on this tooth. So for the avulsion, some of the possible healing responses, ideally we have a normal PDL and cementum and the tooth is fine and good. If there's any kind of damage in the cementum and the PDL, we're going to get surface or inflammatory resorption because those osteoclasts aren't going to be able to differentiate what's going on there, and they're actually going to start treating that like a foreign body. So we can get either resorption or we can get replacement resorption where some of that cementum gets eaten up and it's replaced with bone and we get ankylosis. And especially in a young patient, that's bad because as they grow, that tooth is, you're going to notice it's going to go below the plane of occlusion and not look great. So again, just kind of go over this table here that's in this Colleagues of Excellence again, your splinting time. So some things you can use for splinting: passive wire if you have braided wire or some kind of orthodontic wire, like a really light 9-tie wire. Heavy test fishing line. I've used ribbon before. That's really nice. That can be difficult to clean up sometimes depending on the situation. Or an Essex retainer if you don't have anything else. But remember, you'd have to take an impression for that, or even these days, maybe scan them and do a suck down on a 3D model. But I had one patient before that I used an Essex on because we took him out of the splint. He was still having some mobility after several weeks. So we left him in an Essex for a while until some of that mobility went away. Another outcome here is calcific metamorphosis. That's possible with any vital tooth injury. So the canal space is going to get obliterated by dentin. Sometimes you'll have a thin ribbon of vital pulp remaining, but not always. It could test non-vital, but if it's asymptomatic, you often want to leave these alone. And you're only going to treat if it's cosmetic and the patient wants to be done with it. So I'm going to talk a little bit about apexogenesis and apexification. So the difference with these, so apexogenesis, we've had trauma, we have some kind of immature tooth, and it had a vital pulp. And we either have a carious exposure or some kind of trauma. So we're going to do a pulpectomy, either like your spec pulpectomy or a deep pulpectomy, and place calcium hydroxide because we want the root to develop further. So by not doing a complete pulpectomy, the tooth is allowed to gain length and thickness of root. And then it either may remain vital at that more apical portion, or we can do a root canal and we'll have an apical stop. So we can restore it normally if the tooth remains vital, and then we do a root canal if it becomes non-vital. So again, that's showing this very deep pulpectomy, not all the way to the apex, and hopefully the root continues to develop. Next, we talk about apexification. So this is an immature tooth that becomes non-vital. So that's pretty key there, non-vital. Again, either from caries or trauma. So we're going to do a pulpectomy, and then we're going to place calcium hydroxide. And what we're trying to do is get an apical stop so that we can obturate it later. So that's not just an open apex. We're not going to get increased root length, and we're not going to get any thickening of the root. So these teeth can be very, very weak later on down the road and may need to be removed. MCA and our bioceramics either can be used for an immediate apical barrier. So you can go ahead and do your pulpectomy, place your apical barrier, and then obturate that same day. So again, here's some photos showing that. So this is kind of new revascularization, or what they call Regendo. Basically what's happening here is we have mesenchymal cells in the apex, these scaps, that we're trying to stimulate to regenerate the pulp. So we're disinfecting the chamber. Again, we have an immature apex here. We're disinfecting the chamber. We're not instrumenting it very much. We're just trying to get bleeding, because that bleeding is going to make a scaffold for those mesenchymal cells to create a new pulp. There's a triple antibiotic paste that they use, that they place in there repeatedly until we get resolution of a lesion, and hopefully get continued root development. So these have to be followed up a lot. I personally haven't done this. One of my co-residents did, and after about a year, they did get some vital tooth tissue back, but not really enough, and they ended up doing a root canal anyways. But this is kind of a new and upcoming thing. So a little bit about resorption. Comes in a couple different flavors here. So first we have our external resorption. So your canal, you're usually going to be able to see that through the lesion, and it's usually going to be kind of asymmetric with very poorly defined margins. And it's going to shift off the canal. So when we do our shift shot, it's not going to stay centered on the canal. It's going to move mesial distal or inferior or superior. Next, we have our internal resorption. So we're going to have an enlarged canal area, and you're usually not going to be able to see the canal through the lesion. Usually very symmetric and well-defined margins. And if we shift our x-ray, it should stay centered with the tooth. Next, we have our invasive cervical resorption, and I'm seeing more and more of this as I know what to look for. So Hitherstay has this classification for it. This tooth is often going to remain vital. There's usually some kind of break, again, in the PEDL and the cementum that allows the osteoclast to invade, essentially, and start resorbing the tooth around the pulp. So you can see in those photos, the pulp is spared. So oftentimes these aren't caught until too late. You'll find them incidentally. I don't have a picture of a radiograph on here, but often incidentally you'll see these. So there's some thought that ortho may cause this or some other kind of trauma. They're not exactly sure what's causing it, but this is another type of resorption to be aware of. So let's just briefly talk about some other endodontic procedures like retreatment, apicoectomies, and internal bleaching. So first of all, let's talk about success. So this is an older study, but kind of a classic study. So overall success for root canal treatment is about 91%. It depends on the study you look at, but success rates are usually pretty high. Now, if you have a vital or non-vital pulp and no periapical pathoses, your success is pretty high, 96%. If the pulp is necrotic and we have a periapical radiolucency, your success goes down to about 86%. Then when we talk about retreats, again, if we don't have any periapical pathoses, about 98% success rate. If we do have periapical pathoses, our success drops significantly down to about 62%. So things to keep in mind when treatment planning a retreat. So what are some etiologies of endodontic failure? Why would we need to do a retreat? So a good mnemonic for this, poor past in the AM. So a perforation, incomplete obturation, overextension, so got to perch out the apex. We've missed a root canal, some kind of periodontal involvement, making an endoperio lesion, another tooth, a split tooth, trauma, some kind of anatomic variation, or micro leakage. So when we talk about endodontic retreatment success, Gorney and Gagliani kind of have a classic study here. So again, overall success rate in their study was 69% for retreats. They said if you respected root canal morphology, so no ledges, no instruments left behind, you should have an 87% success rate. But if it's not respected the anatomy, then you're about a 47% success rate. So also, it's really important to retreat if you're going to do root end surgery. That's going to elevate your success rate for an apico, so doing the retreat first. So when we're looking at doing a retreat, you got to ask yourself a couple questions. Can I make this situation any better? Does this root canal look pretty good? They're still symptomatic. Yeah, maybe I can make it better. And is this a key tooth? Is this a tooth that's really important for me to retreat, or are we better taking the tooth out and doing an implant? So, implants are a great option. They're not always the best. Sometimes in aesthetic situations like the anterior, we are better off trying to save a tooth if we can. But there's some situations where it may be better to just cut our losses. So apicoectomy. So apical surgery exposes the root end and allows for removal of foreign objects, diseased tissue, areas that are hard to instrument at the root apices. So we have previous non-surgical root canal therapy that failed. Maybe we're trying to retrieve an instrument, or maybe we think there's some sort of root fracture, so we're doing exploratory surgery as well. So some indications for this. So we're inability to breed the apical canal. So there's a lot of variations in the last 5 millimeters of the root. So that's often the part that we're removing, the disease part. Again, those anatomic variations, some sort of obstruction, whether it be an instrument from another provider or yourself, or a ledge you can't get around. Any kind of iatrogenic issue, again, separating an instrument, gross gutta perch overextension, perforations, if you have some kind of progressive root resorption, persistent post-op disease, so you've done a root canal, it's just not getting better. And then always important to remember that it's good to do a biopsy after these. So let's talk about a root end filling material. MTA, or as Portland cement, that's kind of been our gold standard for a long time here. It's got a very long set time, 2.5 to 4 hours, but it's got a really good seal and it's very biocompatible. We get cementum overgrowth. These new bioceramics, again, very similar to that endo sequence I talked about. They have a little bit better handling properties. So MTA is kind of like wet cement, or sorry, wet sand when you're handling it. The bioceramics are a little bit easier to handle, more of a paste, and they're going to set a little bit faster. So we're starting to use those a little bit more in these situations. A little bit about internal bleaching or walking bleach. So first we want to remove any kind of discolored dentin. We want to clean the chamber really, really well. And then really important to put a protective base over our gutta percha that's at least 2 millimeters thick of some kind of resin or glass ionomer. And we want to do that to the level of the adjacent CEJs. Then we're going to make a paste out of sodium perborate and sterile water, and then place a temporary restoration over that and reevaluate and repeat as needed. So these can turn out very good sometimes. I have had some rebound ones. So discoloration can return over time. Oftentimes you just go back in there and redo it. So post-bleaching cervical resorption is a real problem. This is how we avoid it. So if you don't put a base over your gutta percha, you're going to see it in about 2 to 7% of cases. If you use a base over your gutta percha, not very likely that you're going to get the resorption. We want to avoid using heat to activate it, and then also avoiding the use of high percentage hydrogen peroxide, superoxyl, 30 to 35%. Again, we want to ensure we have good canal obturation and that base protected, and then make sure we're taking recall radiographs periodically to make sure no resorption is occurring. If we do get it, we can go in there and place some calcium hydroxide or repair it surgically. So a little bit out of the endodontics, but I just want to talk about improving success as we wrap things up here. So Aquilino did a study, and he talked about the relationship between crown placement and the survival of endodontically treated teeth. So root canal treated teeth without crowns are lost at a rate 6 times greater than teeth with crowns. And that's when they controlled for the type of tooth and then the amount of caries. So second molars and teeth with caries at the time of access were lost at a greater rate. So if you think about it, that kind of makes sense. Teeth with large caries, large restorations, you have a big MOD, you've lost a lot of the supporting structure that gives that tooth integrity. If you've taken away your marginal ridges, especially in a molar or a premolar, you've really lost a lot of the structural integrity of that tooth. That's why it's so important to place a coronal restoration on a tooth after doing a root canal. So another long-term prospective study. So teeth without crowns were lost at much higher levels. And then just kind of another thing to think about here outside of endo, but periodontal status was a more important prognostic indicator in this study. So if we have a periodontally hopeless tooth, is it worth doing the root canal, putting a crown on it? So again, another question to ask yourself before taking a patient down this pathway. Finally, this last study by Guillen that came out in 2011. So he talked about quality of restoration and quality of obturation, because there's a lot of studies that say, if we have a good restoration that doesn't leak and just okay endo, it's going to turn out okay. Or if we have really good endo and a leaky restoration, maybe we may have a problem down the road. But so this study is kind of like a duh, no crap, but the best outcomes are when you have good endo and a good restoration. So putting a good crown on crappy endo is not going to improve your outcome. So when you look at a situation like these, those crowns are very clinically acceptable, but that endo is not. And so you're really not going to make things look better. Clinically, it might look good in the patient's mouth, but obviously the situation is not going to improve. All right, well, thank you for your time and again, your patience with me getting on here. And if there's any questions, I can go ahead and answer those now.
Okay, we have several questions, so give me one moment. It says, could you have condensing osteoitis on vital teeth?
Yes, you can get condensing osteitis on vital teeth. You can often see that, you often see these incidentally on like a pano or a PA that you're taking another tooth. So any kind of irritation can cause that condensing osteitis. So if you have caries that are removed, you have some low grade, because it's usually a low grade inflammation that's causing that. Perhaps maybe even in a situation where you have a bruxer causing some inflammation in the tooth. or some other kind of trauma. But like, yeah, so like a reversible pulpitis could definitely cause that.
The next one says 8% NaCOL. I thought it was 6%. Just wanted to make sure it was not a typo. Thanks.
I believe it is 8%.
Can a diagnosis be both symptomatic irreversible pulpitis and symptomatic apical periodontitis?
Yes, yes, you can have SIPSAP. So you can have symptomatic irreversible pulpitis and symptomatic apical periodontitis. Absolutely.
Do you sometimes find it difficult to identify offending tooth during an emergency visit? Multiple teeth symptomatic? What do you do? Antibiotics, recall, allow issue to localize?
So the question asker kind of answered their own question. Yeah, that's very true. So you may want to try to get the pain localized. So again, sometimes they don't present right away, and it's hard to localize it. And you don't want to jump into a root canal if you aren't 100% convinced of which tooth it is. So antibiotics I may be plus or minus on, especially with without any kind of abscess or anything like that. Antibiotics, when we use those in situations like that, we're often treating ourselves, not the patient. Very little of that antibiotic is getting into the pulp. But if that makes you feel better, I'm not going to tell you how to practice. But giving the patient more time to kind of marinate, if you will, and figure out which tooth it is. Again, selective anesthesia can be good too if you're between two arches. But the mandible can be kind of hard to try to localize a tooth sometimes. So again, selective anesthesia can sometimes be used. I've never used a test cavity. I think there's some endodontists who have, where you just go ahead and drill into the tooth to decide that that's the tooth. It is a viable option. I don't think I would ever do that. I don't think I'd be ready to do that. I'd rather wait. So sometimes that tincture of time and letting the patient work things out can kind of help them figure out what's going on, if that makes sense.
Immediate vitality readings can be inaccurate. Sorry, my screen just moved. Immediate vitality readings can be inaccurate. How do you handle that when you get patients with dentoalveolar, you know what I'm trying to say, trauma?
Oh, yeah. So what I think the question asker is saying here, so yes, immediate pulp vitality tests are very inaccurate when there's immediate trauma. The reason we're getting those pulp vitality tests is to get a baseline, because we're going to follow that patient over time. So you're absolutely correct. If I have intrusive luxation and I don't have a blood supply, that tooth's probably going to test necrotic. The reason we're getting, again, that vitality test is to follow them over time.
Okay. In the avulsion slide, I lost connection. What did you say to soak the tooth in before reimplanting? It reads F.
Okay, so that should be sodium fluoride. To just read, let me go to that slide and see what that says. But it probably should say NaF, so sodium fluoride. Yeah, so F minus. So it really should be sodium fluoride.
Okay. Is pre-op PA still standard of care for RCTS? Okay, if CBCT is not available in clinic.
So absolutely. So, those guidelines about the cone beam, it's highly recommended. The cone beam still isn't, I actually just sat in on a endo cone beam CE last week, and it's still not the standard of care. Your PA is your standard of care, continues to be that. The CBCT is just a very useful adjunct.
NaOCl dilution reduces all beneficial effects. Is he recommending not to dilute?
I am, in fact, yeah, you should use it right out of the bottle. They also sell some pre-mixed dental type sodium hypochlorite. I can't think of the brand off the top of my head, but it already comes in a syringe with the safe-ended needle in it. It's a one-time use. So that's like medical grade, if you will. So if you don't feel comfortable drawing sodium hypochlorite out of a Clorox bottle, they do sell it in pre-mixed syringes.
This one just reads, please define success.
So success, that's actually a good question. So symptom-free and functioning is success. So if that makes sense, how else do I want to say that? So I didn't get into this very much with radiographs, but you may take a radiograph of the tooth and see a periapical radiolucency years later. Sometimes those don't always resolve. So if the endo looks good, because you can have a scar there, or might not, the lesion may not totally heal, or it can take up to 4 years for those lesions to heal. So if the patient is symptom free and the tooth is still in function, that's kind of one of the definitions of success.
Some research talk about a lower effective concentration of NaOCl, even 5.2% and lower. Are you stating that the gold standard is 8% and that diluting reduces benefits? It has been shown that if it's lesser concentration, you can just expect to use more, but it's still effective. Should we go by the 8% gold standard or revert back to past information in the study guide?
I'm not sure what he's referring to with or she's referring to with the percentage, but I would, whatever comes straight out of the Clorox bottle, that 8%, that's what you should be using.
Strike, sorry, there's some of these questions. For the success question, a follow-up success, how long?
How long? That's kind of a tough, that's a tough one to answer. Some patients get immediate relief from surgical root canal therapy. If you have an open apex, the patient might be painful for a while because you've extruded some materials out and there's still going to be some inflammation there. So that's kind of a tough question to answer in one shot. But again, if you have a tooth, so I'm going to just make a hypothetical. So again, if that endo looks good, you have a good solid fill, you have a good restoration on it, and the patient is biting and not having pain, and that if you're following up with radiographs, that periapical radiolucency should shrink over 4 years. If it didn't, and the patient's still symptom free, that's a conversation you can have with the patient about whether you want to do root end surgery, if you think you need to retreat that. But again, if they're not, they should be symptom free relatively soon, within days to a week, depending on how badly infected the tooth was, how bad the pulpitis was. So there's a lot of factors in that. We're not talking about trauma either, but I would assume within a week or two, most patients are going to be feeling better. And most standard cases, your irreversible pulpitis, that hasn't been long standing for very long.
So it says the following question is on the review test. The answer was both true. Your thoughts? Sodium hypochlorite can be diluted from 5.2% to 2.6 solution for endodontic irrigation. The weaker solution is as effective in killing bacteria as the stronger solution.
If that was on the study guide, I don't make this lecture based on that necessarily. We're not allowed to talk about those sorts of things. So If that's on the study guide, then I guess I would study that information.
So just keep in mind the questions that come out of the study guide are all based on literature. If you look at the back of your study guide, or if you have it on the computer, go to the reference section. You will see that every question is referenced. You can go back to that reference and look up the information.
So I may not go back to me, but the studies that I was taught are the ones that say 8%. So there are probably studies out there, and I want to poo-poo what the study guide saying. You can you can find a study for almost anything. So the way I was trained, 8% is right. If you are comfortable using 2.5%, I'm just lecturing to you on what I do and what my standards are. So.
What are indications for NSRCT for internal and external resorption, and what does the NS stand for in that?
Is there I wonder what slide they're talking about. Let me see here. What was the last part of that question again, Chris? I'm sorry.
What does the NS stand for in NSRCT?
Oh, non-surgical. Okay, I see. So NSRCT is non-surgical root canal therapy. So that comes from the AE. And then the other part of the question was about treating resorption. Is that correct?
What are the indications for NSRCT for internal and external resorption?
So for internal resorption, if there is enough of the root remaining, let me go to that photo of the internal resorption. So that's a tooth that you probably could treat. So what you're doing there, let me find that. You're never going to be able to get that resorptive lesion is round and pretty large. You're never going to be able to get into that. So you're gonna do the root canal, and you're going to place calcium hydroxide to kill the cells that are causing that resorption. Here, so actually this tooth is actually toast when I look at this. So when you I'm going to put this back up for a second here. If you look at the walls of the root, that resorption has completely gone through there. So and we have this large periapical radiolucency. This is not a tooth that you would treat with a root canal. Now, if you had a much smaller localized resorptive defect and you caught it early enough, you could go in there and do the root canal, place some calcium hydroxide, and hopefully kill the cells that are causing that resorption. For the external resorption, that's a little bit harder and depends on how large it is. So some small defects, sometimes you can flap the tooth and go in there. You don't need to do the root canal. If it's a very shallow defect, you can clean that out kind of like caries, and then place a glass ionomer restoration. I think some people will place like a acid etch or EDTA before doing that too, to make sure that any of the cells that are causing the resorption have been eliminated. If it starts getting to some large or some of those hither stays, for instance, and again, this is when cone beam is nice because you can look at a 3D X-ray of the tooth and see how much root structure is left. Because at some point, you're going to get to a point where there's nothing you can do and it's gone too far. But a hither stay 1 or a 2, you can go in, do the root canal. Again, you're placing calcium hydroxide and changing the environment. That pH changes the environment around the tooth and can slow or stop the resorptive process. Now, with the hither stay, the invasive cervical resorption, that doesn't always happen. Sometimes you can go in and do a repair. So you can do the root canal, and if you have a dental operating microscope, and I don't do a lot of this because I'm not an endodontist, but you can actually take some of those putties, those bioceramic putties, and repair a defect. But that's some Endodontics at that point. But those are the two situations for the internal resorption. I would do a root canal for that one. And for the external, you could either do a root canal, or if it's a shallow defect, you could, again, flap it. If you could get access to the lesion, clean that lesion out, and then repair with some glass ionomer.
What are your thoughts on gentle wave system for endo?
I don't use that system, so I can't really speak to that, to be honest.
What irrigant do you recommend in patients with a bleach allergy and a chlorhexidine allergy? Came across this a few years ago and referred to the endodontist. I was just wondering now what they use. Thanks.
I mean, in a situation like that, you'd probably just be doing sterile saline. I'm not sure. You probably could still use your EDTA as well. Those are two irrigants that are pretty safe. Obviously saline's pretty neutral. for a patient. So there are some thoughts, some older research that dilution is the solution to pollution, that just irrigating with anything would be effective. But I would guess that your prognosis for long-term success would be guarded, and so you need to have that conversation with that patient that if you're allergic to these medicaments, I can try to do the root canal, but I can't guarantee that I've killed all the bacteria. If you've instrumented and flushed the bacteria out and gotten them to a certain level where it's low, and you seal it pretty well, you should seal them off from nutrients and prevent any spread. So in theory, that could work.
What is the effect of IRM or eugenol-based materials when they come in direct contact with the pulp? For example, a pulp exposure.
Off the top of my head, I don't know how IRM affects it. So a lot of materials are pretty cytotoxic to the pulp initially. Even Vitribond is a little bit cytotoxic while it's setting. So even though it's an inert material initially, it may cause some localized inflammation. So if you have a pulp exposure, mechanical, you're often better off doing like an MTA. Biodentin isn't their good one, something like that. Vitribond would probably be one of my last choices. I don't know if I would use IRM. I don't know how irritating the eugenol in the IRM would be. I'm not aware of any studies or anything that talks about that. I think people used to use that a lot. I'm not super familiar with how the pulp reacts to that though specifically.
You mentioned soak gutta percha in sodium hypochlorite prior to placing. Do you just let it air dry? If so, for how long?
My assistant's usually the one doing that, but yeah, you can probably just let that air dry. So if you're planning ahead, you got some other things going on and you're mixing sealer and stuff like that, I don't think you'd be wrong to soak it and then just take a sterile gauze and wipe it off as well.
What is the recommended obturation technique? Lateral condensed or single cone with BC sealer?
I haven't seen studies on that. I know a lot of the endodontists are doing that, and I don't know if that's out of convenience and time, or if that's more effective. Warm verticals used by a lot of people, that's a good way to obturate. And single cone seems to be at this point a good way to obturate. Keeping in mind, like I said, the ability to retreat when doing endo with these BC sealers may be very, very difficult. So if you are going to do that, that may be a case where you've retreated or you don't think that a retreat would be good in the future. This is this tooth-only shot. You're going to give it the root canal. And if it fails, then we're looking at another option.
Would you explain in what scenarios you would prescribe antibiotics?
So host response is really important with antibiotics. So a lot of these, so I'll tell you some of the ones where I would not. So your irreversible pulpitis, symptomatic irreversible pulpitis with symptomatic apical, your kind of classic toothache, I wouldn't necessarily put those on an antibiotic. If I had a draining fistula, I wouldn't necessarily put that person on an antibiotic. If I have a patient that's immunocompromised, an older patient who I might think that their immune system's not great, those are people that I would think about doing antibiotics. If they had a pretty large abscess, and I thought that they weren't, some patients don't have the greatest hygiene either. And if I've gone in and like IND'd them and I don't think that they're going to keep things clean, maybe that's a person I'm going to put on antibiotics. But I wish I knew off the top of my head. I will look it up when we get offline here, but I believe the ADA put out in the JADA, I think last year, a pretty good guideline for when to use antibiotics and when not to. So I owe you guys that. I will look that up.
At what step of root canal treatment radiographs are must from medico-legal aspect, pre-op, PA, and at obturation if using apex locator?
So from medical legal standpoint, I would say the for sure one is you want to take a pre-op and a final. Because again, especially if this is a patient that was not yours before and someone created some other sort of problem that you're now dealing with, you want people to know that that was not your problem, that someone else did that. So pre-op is always good, just also to prove that you've made your diagnosis. After that, I think a final from a medical legal standpoint are probably the only other ones you need. Working length is definitely good. You don't always, I like to take a master cone because I don't trust myself always. But that was one that you could get away with if you trust your apex locator. You took a good working length film and all that's matching up with your gutta percha and you feel good just sealing it off and then taking a final radiograph, that's fine. But I usually like to take a master cone, but I don't think medical legally you need to take a master cone film. So to answer the question, I would definitely take a pre-op, a working length, and a final.
So this was the second part of it, and I'm pretty sure you just answered this, but are radiographs required to be taken with file for working length when using apex locator?
Yeah, it's still a good idea. You can get false positives. As Dr. Cabanata-Loga used to call it, you can get glitter down in the canal. If you're removing an amalgam, you can get some glitter or some silver, amalgam down in the canal. You can touch a large amalgam or a PFM crown and get some false readings. So if it's they're usually very, very accurate. Or if you have a wide open apex, that can kind of ruin your accuracy. So it's really good to confirm. When you look at that shebang study that I talked about earlier, it's super accurate, but within plus or minus a half millimeter. So a half millimeter could be out. Radiographically, if your gutta percha is at the apex, you're probably out, actually. So you really do want to be a little bit short. I've been told, in the Army we're not like this, but in the real world, I know a lot of endodontists like to go to the apex because that's what GPs want to see. But that's not actually, they're doing that to make the GPs happy. That's not actually the best way to do it. You can oftentimes be out of the apex when you do that.
Can you go over GAC? Was that a granuloma? What kind of periodical radiolucency?
So GAC is the 3 kinds, and let me find that for you. So your most common is going to be a granuloma. So you have granulation tissue, and the body's trying to wall off the infection. I'm trying to find this and pull this back up. Your abscess is your A, and then your C is a true cyst. So granuloma, abscess, and then cyst. Let me try to find that slide here. Okay. So again, granuloma, abscess, or true cyst.
Okay, we have several more questions, but we have run out of time. I want to thank you, Dr. Hoffman. Ladies and gentlemen, that concludes the presentation for the virtual review course for tonight.